You. Excellent presentation. Normally after lunch, melatonin kicks in and we get sleepy, but we are bombarded with a lot of good stuff and it's keeping us awake. Thank you again. Now I have the pleasure of welcoming back by Zoom Dr. Valarie Bluebird Jernigan. She is Professor of Rural Health and Director of the Center for Indigenous Health, Research and Policy at the Oklahoma State University Center for Health Science. And she's going to be presented by Zoom. Welcome, Dr. Jernigan, again.
Great. Okay, sorry about that. It was hiding from me, but it looks like it's fixed now. I want to start with the acknowledgments. Thank you to the Roundtable and the Planning Committee, and thanks to my partners, Choctaw Nation, Chickasaw, and Osage Nations. I'm going to be talking about some of the work we're doing with these tribal nations. Our work is funded by NHLBI and National Institute on Minority Health and Health Disparities, and those are our funders. I'm going to be talking today about the THRIVE study, and THRIVE is a study that is purely an environmental intervention. The focus came out of some preliminary work that we did, and when I say we, I mean my colleagues and I at University of Oklahoma, Oklahoma State University, and the Choctaw and Chickasaw Nations. We were looking at obesity and food insecurity in both nations in rural Oklahoma. And we found that obesity was quite high, and diabetes and hypertension were also very high, and that those who were food insecure had higher prevalence rates of diabetes, obesity, and hypertension, even after we adjusted for age and gender, education, income, and community. So part of what we also learned was that nearly, it was 60%, it was actually a little higher than that, of the Native people that we surveyed reported shopping for food at what are tribal convenience stores. And I'll show you a photo of those momentarily. They shop for food 3 or more times per week at these stores. And so that influenced our decision to design an environmental intervention that would focus on the convenience stores in Choctaw and Chickasaw Nations. And to guide our study, we used the Rutten model that was developed by Dr. Rutten and also Dr. Mary Story, that's a systems approach. And it presents food insecurity as running parallel to the larger food and nutrition subsystems and processes. And it was one of the very few models that we could actually find that included both food security and as part of the larger food system, and it included health outcomes. And it also served as a guide for us to be able to map the food system and to understand the influencing environmental, social, economic, and human factors that were contributing to food security and some of the health outcomes that we were looking at. And so using that as our conceptual model, we basically started to explore what these convenience stores looked like. And there are a couple pictures here that you can see. This is one of the stores in the Choctaw Nation and one of the stores in the Chickasaw Nation. I wouldn't call these corner stores because they're different than what you might find in an urban environment. They're located in very rural areas. The map there shows you the red dots are the places where these convenience stores are located. And they include not just packaged foods, but hot boxes, which are basically pre-fried foods that are sold, like chicken nuggets and that sort of thing, French fries. And they have smoke shops in them as well as miniature casinos. So they're really a place where a lot of Native community members not only shop, but they actually hang out. There's some tables and chairs, meet each other there, drink a cup of coffee. And so it's a place where people often gather. They even have birthday parties inside them in some of the really small towns. And the convenience stores serve as the caterer to some of the sports teams in the towns as well. So our design, it was a cluster control trial with 8 stores, 2 tribes per store assigned to implement the intervention, and 2 stores per tribe assigned as the control store. The longitudinal cohort study, so we surveyed about a little over 1,600 Native shoppers before and after the interventions. Our store level changes were changes in fruit and vegetable availability, which we used the nutrition environment measure scores. We actually adapted that to be appropriate for the tribal stores. And we also had access to the sales data from the stores. And at the individual level, we looked at perceived food environment changes and intake of fruit and vegetables. And these were measured by self-reported questionnaires. And the strategies that we were adapting to be appropriate for the tribal stores were guided by recommendations from this committee. And we looked at basically the 4 Ps: product, placement, promotion, and pricing. So phase 1 was really focused solely almost on products, because we needed to know, how do we get food available in rural stores, and what are our options? So we did a very extensive inventory using NIMS, the adapted NIMS, to establish baseline scores for these stores. And then we did a comprehensive nutritional analysis on all the foods that were sold, as well as foods that were potentially available by the vendors but weren't being sold in the stores. And that established a baseline, and it established our options. Once we got a set of options, each tribe established criteria that they wanted to include into the study, what was considered healthier foods. And those criteria were basically 10 new snack options that were 250 calories or less, and 5 new meal options that were 500 calories or less, and the fat content was 30% fat or less. The next phase was really focused on the remaining Ps. So once we had product that we were getting ready to, we knew we could secure, we focused on placement, promotion, and pricing. And so that really involved, how would we stage these kinds of interventions in the stores? Where would we put them? How would we promote them? And what would the pricing look like? And that involved numerous focus groups with shoppers, as well as convenience store workers. And we finally settled on, these types of strategies. For the placement, you can see we went into the stores and we moved the hot boxes to behind the cash registers, and we placed open air walk-around coolers in the front of all of the stores. The blue is the refrigeration units, and the red is the intervention foods that we introduced. We were able to stock the intervention foods in high traffic areas around the cash registers, in the new refrigeration unit, and at the end caps, the end of the aisles. And this is the shelf, an example of a shelf planogram, how we basically designed the interventions. This is an example of our promotion strategies. So you see the fresher choice and the better choice, and we translated that into tribal language. so that could catch shoppers' eyes. And this is another example of the promotion strategies that we used. For pricing, we actually had some special deals that were 2 for 1, and we actually didn't end up having to change the pricing of the foods from standard suggested retail price because of their selling. So we never actually had to adjust that, though as part of the study we did build in compensation for the stores should the food products not be sold, but they ended up selling every week, and so we never had to compensate the stores, nor did we have to discount the foods. In one of the tribes, it was virtually impossible to get products that met our criteria, and so the stores actually in the Choctaw Nation had to do some remodeling to be able to order bulk produce and pack it themselves to create intervention foods. And this is an example of 2 of those new meals that were introduced. These are our statistical methods. We looked at loss to follow-up compared to those completing the follow-up surveys. For the intervention stores, we looked at promotion effects, so promotion signs, recall, whether or not the person purchased the promoted product, and the effect of the sign on the purchasing. Intervention versus control stores, we looked at changes in the nutrition environment measures, survey the perceived nutrition environment, or NIMS-P, and we had a survey that measured food and beverage intake of specifically the intervention foods. We looked at effective dose of exposure to intervention, so frequency of shopping at one's home store was our dose, and the exposure was the number of times that somebody reported shopping at their store. We did chi-square for categorical variables, t-tests for continuous, trend analysis for dose effect, the frequency of shopping, and confidence intervals for changes over time. So just a couple of outcome slides. The perceptions of healthy food options changed. I don't have time to present all of the data, but this shows that our participants in the study did report significant increases in the placement and promotion of healthy items, as well as availability of healthy grill options, while these remained essentially the same among the control store group participants. And the between group effect was also significant for changes in placement and promotion of healthy items. This is the objective NIMS measure. So you can see on the left is the intervention store, and stores in the right is the control, and pre and post the availability of fruit and vegetables and sandwiches, wraps, and burritos increased in the intervention stores significantly. So looking at our trend analysis, this shows a nice significant effect with the purchasing of fruits and vegetables. So the more someone shopped at the store, the more likely they were to notice the reach-in coolers, notice the signs, and purchase the fruits or vegetables from those reach-in coolers. So in summary, Thrive improved the objective and perceived measures of the tribal food environments, and our paper on this just came out in American Journal of Public Health in January, so you can read more details there. It led to changes in purchasing behavior among shoppers, but we didn't see changes in intake of fruits and vegetables. We think there are several reasons why. One, our measure, we didn't do 24-hour dietary recalls, so our measure might not have gotten at really how people's intake, could have changed. We only changed the environment of one small component of these communities, the tribal stores. We didn't do larger environmental changes. We didn't focus on individual level behaviors. So those are some of the reasons we think we didn't see changes to intake. But the study did result in widespread policy changes. In order to offer the foods that we needed for this intervention, the food vendors had to make some changes to which farms they used and where they got some of their foods. And both Indian Nations Wholesales, which is one of the vendors that the tribe uses, actually that as well as the other one changed to offer a larger variety of food options, and those changes were permanent as they didn't want to lose the contracts that they had with both nations. And so that resulted in more choices for all of the different businesses that the tribes operate. So any daycares, senior centers, casinos, hotels, all the convenience stores now have a much wider array of vegetable and fruit options than they did prior to the study. Our challenges, opportunities, and next steps. This was, very structural change. How do you really do this in real world, very rural reservation environments? We, knowing very little about, the food convenience store environment, really had to partner very closely with the economics sectors of both tribes. They were very generous with their time. We spent a year and a half working with them to identify win-wins. They weren't necessarily motivated to make, to participate in a randomized trial initially, but when we were willing to share data with them about preferences and taste test data that, participants in the study would report, they were very willing to do it, and both tribes actually recognized that it would be beneficial to them to make these changes as a way to show the communities that they were committed to health. But it did take some time to recognize and understand that health belongs in all sectors of the tribal nations. It's not just something that we should care about in a hospital setting or a clinic setting. This was the first time that we've thought about health in the business sector, and what does that mean? And so to us, that was a big benefit of the study, getting the health people to the table in the economic discussions, and that had never happened before. Climate change, not to go into that, but it ended up being quite a big deal, constantly threatening the different indigenous foods and lands. It was very hard for us to procure indigenous foods, and we weren't able to do that on a scale that could be sold in the stores, though that is a future goal of ours. Tribal leadership needed the economic information, and so they were willing to share with us the sales data in exchange for us to track and do some health impact assessments with them. That has to be included in interventions so we can plan for scale up and dissemination should the interventions prove efficacious. And really pushing forward the dialogue around what many of you do in this room, which is talking really about health in all policies and thinking about health for future generations. So that was really sort of the story of the study. Thank you very much.